Well, one of the questions I would have asked to clarify, are we looking at a PO2 for a retina, or are we looking at an FiO2 for
We're
that?
looking at mostly an FiO2 that you're registering on, your monitoring is basically we're seeing how the baby is perfusing. And as they're not needing that, we need to be very vigilant about keeping that baby in between target oxygen saturation based on that gestational age for that baby. And in this case, I believe we'll be sitting somewhere between 92 to 88 to 95. That's what we really generally go for. Anything above 95 should be beginning to wean that baby, even if it's just by 1% until we can get them maintaining 21%, which is what I agree.
So it's very important that with the oxygen level in the blood stays at a lower level so that we're not going to be cranking that up super high. So we're going to be starting babies out at under 50% FiO2. That they're setting at 80, 90%. We're fine with that. That's completely normal. So the other modes that you might see, like CMB, every breath the baby gets is going to be the same breath that we dialed in on the settings. Even if they're taking breaths on their own. SIMB is another mode that maybe we'll see very rarely. We're kind of stepping away from it a little bit. So might see that a touch. That more along the line that we'll set tidal volume with 35, and any breath that they take after 35, those are the baby's breaths. So we don't give them as much support. It's kind of a weaning mode. Not a lot of literature saying that it's very helpful. So like we try to keep it on the CMB side. And then the final one is spontaneous. This is more of a weaning. This is when we're trying to get the baby off. We're wanting to see if we're going to be able to tolerate the bed for breathing on their own without their endotracheal tube. So we'll put them on that. The other one that I have on the bed mode is the NIV and the bubble CPAP. So in our facility, we have two modes that we can utilize to give CPAP. This does not require an endotracheal tube. So we can put a baby on NIV, which is basically two types of support. You're a pressure support when the baby's taking a breath in, and you're getting CPAP to help keep those lungs open. Or we can put them on a straight up bubble, and that will just give straight CPAP for when the baby is working on it. So,
And these have really changed the way that we utilize ventilators in our units. Have been able to extubate very tiny babies successfully onto NIV, or you sometimes will hear NIPPV. This is non-invasive ventilation, meaning there's no endotracheal tube. Bubble CPAP is just straight bubble CPAP through a prong. We are currently using ram cannulas in almost all circumstances in the NICU. Knowing a ram cannula does not give true peak to the baby. You will always have more of an 80% rate of whatever you're setting the machine at. So if we see a peak of 6, you're really getting like a 5 and change on there. So it's really important in our world that we understand the differences of that. When we're in the OR or in the delivery room and we're giving mask CPAP, that's true CPAP. You're setting the peak, the positive end expiratory pressure of that machine. And when you're including that onto the baby and achieving where you set that, it's very important that we're not overcompensating, because that can blow a pneumothorax or cause more distress for the baby. So it's super important to understand the difference. If we're using the ram cannula in the OR, you're not actually getting that full true CPAP every time you're doing that. So you have to just be very careful with true CPAP, because you can absolutely overinflate the lung rapidly and blow a pneumothorax. When we have these little babies and we're giving surfactant, it's really important, because once you make that lung very compliant quickly with the surfactant, they may not need that pressure, that peak that you could get into that baby, where you want to take it down a little bit, because now you've made the lungs a little bit more compliant, and you could also over distend the lung and cause pneumothorax.
absolutely.
So those are good things that we teach a lot, and know the difference between why we're using the ram cannula and what true mask CPAP is for the baby.
And one of the things that everybody might see differently when we go to the 30 weekers is that we do have what's called a trunk system CPAP, which is true CPAP for nasal CPAP. And it is a mask that goes over the baby's nose. And it's a headpiece that we put on the baby. We have not had to use that here at Altamont since we've gone to the 32 weekers, but that might be something that we might have to think about utilizing when we go down to 30s. So that is just something to keep in the back of your mind. Now that we've kind of gone over what we're going to set, how we're going to set it, let's talk about a little bit about what to expect with a ventilator. So like, this is the thing I think nursing has a big problem with, like, because they don't see the ventilators every day. Us RTs, we live in the adult world lots of times. So like, we're around vents all the time. We're utilizing them all the time. So some of the things that you're going to hear is that they alarm all the time. The vent is constantly alarming. You want to squeeze the band to see if you can get it to alarm.
That is
Yeah.
right here.
That's a typical alarm you're going to hear going off on a baby. It has three alarms. You have the one. It has three different alarms. It has the one little beat. It has the two little beat, and then if you ignore an alarm on a bed, it will screech at you as high as it can go. So like, we really don't want to be ignoring all events, but we also don't want to be scared of them. Like, that's keeping the baby alive, and they're most likely something going on with the events alarming. So the main things that you're going to see when a ventilator is alarming is that the baby probably needs to be suctioned, which there will be a suction catheter right on the tube and suction the baby with, and so down and up. And we'll be going through all of that with training. There might be crud that built here in this part of the tube, just like on the nasal CPAP, where you get water that builds up. We get water that builds up in the flow sensor, and that's a simple solution. Anybody can fix by just disconnecting right here and letting the water drain out. And then we have crud in the tube, crud in a circuit. So if the baby's really juicy, we can get a bunch of crud that built up in here. And also at that point, we need to empty it out. Is that something that we really want nursing to do? Probably not. It's probably at that point we're going to need RTs to come up and come with it.
And a lot about crud, what is mostly what we're dealing with is rain out. You have a heated, humidified machine, which is how you're going to distribute that to the baby. It needs to be heated. It can't be cold air being pushed into the baby. That's very shocking to them and can cause a lot of issues for them. So what you're seeing is this rain out that's happening in your circuit all the time of cool air in here from our environment hitting heated, humidified air over here, creating a huge amount of rain out in the system. And that's where your RTs are instrumental in getting that removed. They'll teach people, they'll show people as we go on how to actually manage this portion of the machine. Just anytime your alarms are going off, until you feel comfortable with your machine, get your RT to come in with you and just walk through what it is that is going on. 9 times out of 10, it's something rain out, crud, some sort of buildup in the tube, some faulty piece of that versus the actual attachment to the baby. The machine is smart. It's just saying, what you dialed me in to do, I can't do it because there's something in the way of that. And it's losing whatever we're trying, whether it's pressure, support, PEEP that we're trying to get the baby. Something's obstructing that line. It's letting you know there's something in here that's not letting me do what you asked me to do.
And we dial and set the alarms, and we intentionally set the alarms low. So like, I want to know when something's happening to a baby. So I'm setting those alarms on that thing to go off to tell me that something's happening to that baby, so that I can come in and take a look at the baby. So that is one of the main, but the biggest thing that I want to make sure everybody is aware of, absolutely everybody's aware of, is when you hit that silence button on that, you never walk out of the room with the silence button still on. It takes 2 minutes for the silence button to go away. You either stay in the room for 2 minutes or hit it a second time, so that the alarms are reset. Because if something happens to that baby within that minute that you walked out of that room, it's really our responsibility. So what are we responsible for? Let's talk about something.
That was a big one.
Yes. Let's talk about something.
So there is, again, a very proper technique and etiquette for suctioning a baby. When a baby is on the ventilator, their natural response is, this is a foreign object that is in my body, and it's going to release a bunch of things that create mucus, white blood cells that are saying, hey, this shouldn't be here. We're fighting this foreign object. which creates a ton of mucus for those babies inside of their lungs, which can clog up that endotracheal tube. It's like breathing through a straw and then somebody sticking something inside of your straw. And it's very frustrating for the baby, can cause air trapping, increase CO2 on the baby, which all these things are not how we want to help this baby to wean off the spin and give them what they need in their lungs to what they're needing for support.